Good morning. Morning. Thank you very much for coming today. I'm Faisal Kaoud, a member of the Committee on Financial Matters and Retirement. And Sandy Haas, the Executive Director, together with me, we cooperated in getting this presentation on. We are grateful and thankful for the 5 speakers who will give us an insight to this important aspect of the long-term health care. And I just want to share with you what the sequence of events is going to take place this morning. At first, we will have John Sauer be our first speaker, followed by Marianne Dreicher and Kelsey Abel. After that, we will take a 10-minute, will be around 11 o'clock, and we'll take about a 10-minute break, and then we'll return, and we will have the remaining 2 speakers, Tim Conroy and Zach Crobart. And after that, we will have a panel Q&A. The 4 speakers will be happy to take your questions. So I'd like to start with introducing John Sauer, who is the president and CEO of the Leading Age of Wisconsin. John has a BS from UW-La Crosse and a graduate degree from University of Milwaukee. And he has extensive experience in government and non-government a nonprofit organization. He was a team leader at the Wisconsin Legislative Fiscal Bureau for over 7 years and has several years of experience in long-term care in Wisconsin. Please join me to welcome John Sauer.
Thank you very much. My task today is kind of get you some overview and broad information, and then the expert panels will fill you in on some things that affect how they provide care and services within their organization. So I am really excited to be able to be here. I wish maybe, the snowfall kind of triggered this, yeah. I'm excited. If we get any more snow, I'm going to start a national petition that we have the holidays moved from December to February, I think. But there has been significant changes in how we deliver long-term care and services in this state and, frankly, across the country. This is a photo taken at one of our member facilities in the 60s. In this day and age where we live now, I suspect this person receiving skilled care in a nursing home would probably be a resident of our independent living facilities. I'm going to talk about some of the changes that are happening. At the outset, I'd like to say I'm going to go at a fairly rapid clip. There are a number of slides. You have them. I'm not going to labor through each one, but the information is there in your packet, or you can feel free to give me a call or email, or maybe in the presentation and discussions later today we can have time to answer some of those questions or engage in further dialogue. But I'm going to hit some of the key issues about aging, the workforce, how payments systems are changing, regulatory, and just consumer preferences. I'm going to try and all do that in a relatively short period of time so you get a sense of what are the major factors that are driving change within our long-term care system. But maybe just to start, we've had in the last decade or so about a 32% increase in the over age 65 population in our state. Can anyone venture a guess as to what, over that same period of time, by what percentage did nursing home bed capacity increase? So I hear 0, and decrease is the answer. It's decreased by 15%. And so the changes are going to continue, and they're going to go in that direction. I'm going to explain a little bit. But at the same time we've had decreased bed capacity, we have, as I said, significant increase in the over age 65 population. The maps basically show the darker the map gets, the older the population is in the state of Wisconsin. So we're seeing a 72% increase in the over age 65 population. For the 85 and over population, between 2015 and 2040, there will be over doubling, 120% increase in that population. With that, we also have to talk about persons with dementia, because about 2/3 of people in nursing facilities and increasing percentage in assisted living, those residents and clients have some form of dementia, and those numbers are increasing pretty similar to the level of increase in the overall aging population. And with that population, the persons with dementia have many comorbidities, and the graph just shows you that generally older adults with dementia also present issues with COPD, stroke, heart disease, kidney issues, and the like. So often they present other challenges, which means they fit somewhere within both the acute and the post-acute care settings. So when we look at, okay, well, that's where the demographics are going, so who's going to provide care to people in the future? And the Department of Workforce Development says we're going to have, over a short period of time, about a 54% increase in the need for long-term care workers, those in continuing care or lifespan communities, assisted living. There's not so much of an increase in staffing increase in skilled care, but there is a need to fill those positions. And so what we have is an aging society, but relative to the workers that are available, as a ratio, that ratio is more difficult. So there are fewer workers per persons over the age 65 to provide that care, and that trend's going to continue. So we, along with other long-term care associations in the state, did a study last year, and it looked at what are the challenges out there for long-term care, and we found a lot of things. First of all, there's a great need for caregivers, stating the obvious. But the other thing is we found 1 in 5 caregiver positions are vacant. Over 16,000 vacant caregiver positions in the state of Wisconsin. And as we flow into the discussions later today, who's going to care for people in what setting, we have to do it in the backdrop of the caregiving crisis that we have in the state. Governor Evers just announced this morning that he's created a task force on caregivers and has a broad charge, and we're pleased that he's recognizing the need to address caregivers, both in the funding, the services, and support, both for paid caregivers and non-paid givers. The crisis really kind of, I won't hammer it too hard, but we've had an actual decline in the number of people that say they want to serve as a certified nursing assistant, those that provide most of the care, hands-on care in nursing facilities and assisted living facilities. We've actually had a decline in the number of people that are coming into the field. We also have a lot of payment changes, I might add, and it changes everything, it really does. But one of the things, if across the state of Wisconsin, if you're a skilled nursing facility, On average, 2/3 of everyone in a nursing home is dependent on the Medicaid program to pay for their care and services. So about 2/3. And the problem with that is, from the provider standpoint, is that Medicaid is a very, very, very poor payer, trying to cover the cost. There's not a facility in the state that's Medicaid certified that gets fully paid for the cost of care for serving the Medicaid population. The overall loss is over $324 million. The average nursing home, just to start their budget, they start with a deficit of $1 million, that they have to overcome and figure out how they're going to shift cost in order to keep the doors open. And the other thing is, there's a not so hidden burden on those who are paying privately. It's over $110 per day that someone who's paying privately in a nursing home pays. They pay more, $110 a day more, than what Medicaid pays for the same service. And so if someone did need nursing home care for a year, that's $41,000 more per year than what Medicaid pays for the same care. And that's the underlying part of the crisis in long-term care. We also have payment changes so that family care, which is an expanded program that is now being implemented statewide, that provides Medicaid-covered services for persons outside of nursing homes who need long-term care. About a decade or so ago, back to 2000, we only had about 2,000 people being served in family care. It's a managed care program. And now we have over 51,000 people, and that pays a significant number of family care residents are in assisted living, and that's a new development. What we have found in family care and in supportive housing, if we can provide some services, some supportive services to older adults in a congregate setting, we can stave off the need for nursing home care. So it's important to have this continuum of care and to serve people and support them before they need hospitalization or before they need nursing home. But there's also other factors, and I don't have time to go through each one. I mentioned payers like Medicare. Medicare is putting payment standards in place that will both reward and penalize nursing facilities that send too many of their residents back to the hospital, or too many residents get readmitted after discharge from the nursing facility. And managed care is looking at freeing up how they pay and paying providers that traditionally were not being paid for to support people in their home or in assisted living. The regulatory environment I have to talk about as a change driver, because in nursing homes it's often said that except for possibly the nuclear energy field, nursing homes are the most regulated entity in our country. And that is done for some assurances, for protection, but I can tell you it also has a chilling effect on flexibility, on creativity, and things like how we staff and how we cross-train people. So some providers are looking at moving away from being licensed nursing facilities, in large part driven by the punitive regulatory system that we have, and that's just a reality. The fourth factor is consumer preferences, and people who are anticipating or need long-term care or are involved in the field are really saying, because we've always done it this way doesn't mean that's how we're going to do it in the future. And so consumer preferences are driving significant change, and I don't want to understate that. So where we are today is, compared to the last decade and a half, we have decreased the number of nursing home beds in our state by 10 or 11,000 beds. We've increased assisted living by almost 30,000 units. and those changes are going to happen. I will mention the same is happening with institutional capacity and services within the acute care setting. So inpatient hospital days are going down, nursing facility days are going down, and expansion of home and community-based services and assisted living is going up. So this is creating some positive things in some ways. The hospitals, assisted living, nursing facilities are all trying to get together and think about how we handle transitions of care. A very positive movement where providers are talking to each other, not just looking at episodic care and you're done, but looking at how do we manage, help people over place and time. And some real healthy things are going on in terms of managing care. On assisted living, we basically have three main types of assisted living: CBRFs, or community-based residential facilities, and residential care apartment complexes care for most of the residents in assisted living broadly. A CBRF, many of the CBRFs are single rooms with an attached bathroom. Many of the CBRFs in the state serve persons with memory care. A residential care apartment complex is a full apartment, as the name might apply. And there, people have their own sleeping area, their own living area, their own kitchen area, and it's a full apartment. But within that apartment, you can provide significant levels of services, and I'll talk and hit on that briefly. But within our assisted living for CBRFs, community-based residential facilities, we have over 31,000 people residing in CBRFs today. In RCAC, those apartments, we have over 15,000 people being served. So far more people are receiving assisted living services than nursing facilities. So in a CBRF, you can provide, and we'll get into all of the details, but both in CBRFs and RCAC, the regulations allow for substantial amounts of nursing care to be provided within those settings. And in fact, when RCACs were created, for some that was viewed as a replacement model for nursing facilities. The main caveat for RCACs is the code says the provider is not to admit people who at the time have dementia and are not their own decision makers. On costs, basically data shows on cost that assisted living is about half of what the cost is of skilled care. So obviously the consumer and those who are paying privately are looking at both the setting and the cost as a driver for change. So I'm going to wrap up by talking about some of the changes that I see happening in long-term care, a little bit of where we see. And this is a somewhat confusing chart, but on the right are services that someone needs. A health episode happens, a fall happens, for example, or a stroke happens, and they need higher intensity skilled services or acute care services. To the left as we go are wants that consumers want, and those wants often, if they're done correctly, can stave off the need, as I said before, for higher level, more expensive care. And that's what the system is grappling with, is how do we finance and make available, and how do people afford to provide services as you move from wants to needs. But I have a couple, maybe 8 really quick prognostications, and I'll go through them quickly. One is that nursing homes are going to continue to downsize, and they're going to do it for the reasons I spoke about. They're trying to find the right size that allows them to be able to financially operate, to attract the staff and have the staff that they need in order to continue to operate. And consumer preferences will be addressed. Nursing home residents will continue. There will always be a role for nursing facilities in our long-term care system. There's just going to be continued changes as we serve residents with behavioral challenges, complex and unstable medical conditions, and other needs. But assisted living acuity is also going to continue to increase, and the level of care that is being provided in assisted living of all forms, that level of care will increase. Just the demographics and how we serve people will generate that trend. Overall, we're going to also serve more people in independent living. The average person in independent living facilities across the state, the average person has some significant health issues and has generally on 8 or more medications. So there is acuity throughout the system. Payers are going to look at outcomes, and I don't have time to go through all that, but performance-based payments, both by Medicaid and insurance companies, will drive further change. And there will be more flexibility in terms of where providers are willing to pay for care and services. I do think we're going to see an expansion of technology as well, and that will allow people to age in place, and we're going to have exciting things like telemedicine and remote testing and lab work being done. And then finally, I will say that as acuity, the level of care outside of more intensively regulated settings occurs, that there will be folks who will look at whether or not we need to change the regulatory system to match those changes. And that will bring further challenges to our field. So as I wrap up, it's suffice to say that change does occur. Change is happening every day in the field of long-term care. But the provider community, especially the mission-driven organizations, like where we are today and represented on the panel, are going to drive change in a positive way, despite the challenges that for some seem almost insurmountable. But we're moving forward in a positive way. So thank you for your time.
Thank you very much, John Sauer. Very interesting presentation. And we are going to have later on, after the break, after we have the two speakers, we're going to have a Q&A panel, so you'll have an opportunity to ask them. Our next speaker is Marianne Dreicher. She's the president of the Attic Angel Community, Attic Angel Place Continuing Care Retirement Center, and the Attic Angel Prairie Point. She works with 3 board of directors, 500 association members, 290 staff, and 360 residents. Marianne has over 40 years of management experience in long-term facilities, including working in county, for-profit, and non-profit organizations. Marianne will identify the factors that influence the closure/transfer of patients from skilled nursing facility to other services, and how patient care is coordinated with Medicare, Medicaid, certified home care agency. Please welcome Marianne.
Thank you. It's a pleasure to be here with you today. I have a wonderful grandson, and I loved having him come visit us. And this last Thursday, he came, visited, and left a cold for me. So please bear with me if my voice gets a bit gravelly. So the Attic Angel Association, many of you may know, we actually are going to be celebrating, or in the middle of celebrating, our 130th year of existence in Dane County, meeting health and human service needs for the children and elderly. In fact, you're all invited to our 130th celebration, Life is a Playground, on July 28th of this year. And as was mentioned, the Volunteers Association is the volunteer arm of the organization. It provides for fundraising, provides the volunteers for the other corporations, and then we have Attic Angel Management Services, which is a new corporation that we just launched, where we can help other organizations to manage the facilities. as well as Prairie Point, which is 123 homes, single-family, duplex, triplex, fourplex, fiveplex homes in a community, independent living, as I mentioned. And then at Attic Angel Place, we have 194 living options. So we have apartments with services, 74 of those. We have 56 more typical household assisted living. We have 20 memory care haven units, and we have 44 health center units. And it's really, I'll concentrate a bit more on our health center and the transition that we've seen taking place there. The licensures that we operated under included the RCAC that John had mentioned, CBRF, and skilled nursing facility. We now are only operating in 2 licensures, the CBRF and the RCAC. So here's some of the headlines that we're seeing in the paper throughout 2016 and 2017. We won't go into a lot of them, but there's a lot of kind of gloom and doom of what's going on with nursing care facilities. So against that backdrop, some of the issues, again, that we're facing skilled nursing facilities. As John mentioned, public and private payers are shifting to a bundled service or patient-driven payment models, alternative systems. And the trend is really for hospitals to avoid discharges to the skilled nursing facility. In fact, we saw within a short period of time where we were serving on average somewhere between 15 to 20 residents per day under Medicare. Within a 6 months period of time, we were down to more like 5 to 7 residents per day. So a pretty dramatic shift of what the hospitals were doing as far as discharging. Again, when the skilled nursing facility is used, the needs are high, very high acuity, very costly. The length of stay also we saw shifting a great deal. That people used to would go to your skilled nursing facility for rehabilitation. They might stay the full 20, 30, 40 days. And we were seeing that shift, and that nationally it was more like 14 days was the average length of stay for rehab. John mentioned the regulations. This new mega rule went in, and we estimated that actually the department estimated it would cost about $60,000 a year to implement those new regulations. In our small 44-bed facility where we were only serving an average of 6 or 7 residents, it would have cost us a lot more than that. What we estimated was more like $200,000 to do the staffing, to do the things that we needed to do to comply with that regulation. And consumers really don't want to go to a skilled nursing facility. I've talked to a lot of seniors, and I have yet to meet anyone that has it on their bucket list to go to a skilled nursing facility at some point. It's just not the preference. But people are willing and see a value in going to assisted living. Again, the average skilled nursing occupancy throughout the nation is down to 82%. That's an all-time low. So with those changes, what were going to be the impact of these on Attic Angel? Well, we would see a continued decline in the number of Medicare residents. As I'd mentioned, that we saw that already, and we thought that that would continue. We also thought that there'd be added costs reflected in the resident rates. As John mentioned, if the payer systems are not paying you what your cost is, somebody has to cover that. And to accept and adopt the new regulations and add that extra cost, it had to be shared someplace, and we were concerned about that. And from the hospital discharge point, we really no longer compete with other skilled nursing facilities as people are going home. They're going home with home health and assisted living. But we'd still have had the added expense of being a skilled nursing facility. And we really, again, we had a 44-bed facility, and it's really too small. We are very proud that we participate in the Leading Choice Network, which is an arm, a division of the Leading Age Wisconsin, where we are bringing providers together to try to negotiate better rates. But in a city like Madison, if you've got only 44 beds and you've got other fine facilities like Capitol Lakes and Oakwood who have many more beds that they can accommodate the needs of the hospitals, that they'd rather have one contract than multiple contracts. So that was a concern that we saw. Also, we were very concerned that really a market differentiator for Attic Angel is our volunteers, the Attic Angel members. They give 34,000 hours a year serving the residents of the organization as well as doing the fundraising. And with the new regulations, our volunteers also would have been impacted, where we'd have to track call-ins and follow up with them, and how long were they sick, and when was your last emesis, and all this type of thing. That we really thought that that would impact their willingness to serve the residents in the facility, and that was just a non-starter for us. And of course, additional requirements for staff to participate in really a lot of non-direct care functions. A lot of infection control tracking and things that were taking people away again from caring for the residents. So, based on all those headlines and the changes and what we saw happening, we had concern, and so we underwent an independent review and received some recommendations from Clifton Larson Allen, their nationally recognized organization, to review data and to do interviews with our staff and residents. They made the final report to the association board in June, and at the July meeting then the board made a very courageous decision, and that was to relieve the organization of the cost of certification of Medicare while continuing to provide that high quality continuum of care. We'll still have, and we still do have, 4 levels of care within our building. But we have more flexibility as to where those Medicare benefits can be used. They also wanted to transition the licensure that allows for a more home-like environment and one that emphasizes social interaction. And I guess the best example that I can think of is my father was in a nursing home in the southwest part of the state. And for years, he had a tradition, and he liked to have a little blackberry brandy at night before he went to bed. It's perfectly reasonable, right? Well, once he moved into the nursing home regulations were such that you can't just have that in your room. You have to have it at the nurse's station, locked. You have to have a doctor's order so that the nurse can administer it. So you have to call the nurse, she has to unlock the medication, she has to pour it for you, administer it. You have to, she writes down how much you consumed. A lot of things that just were not home-like, were not really what we were wanting to be about. So just one of the examples. But we realized that we also wanted to be able to have people utilize some of their Medicare benefits and still get the rehabilitation needs that they would be in need of. And therefore, we sought out and we partnered with Recover Home Health so that we could provide those home health services for our residents in the community. So we had a number of things that stayed the same. We still, our commitment was to keep the direct care staffing ratio the same as it was before, which is well above industry standards. All of the current residents in our nursing home made the transition, stayed in the same bed, in the same unit, in the same room, but now they were covered under a CBRF code instead of a skilled nursing facility code. We recognize that some of the regulations are very onerous, but some of them made sense. They were really good. And so we are in a position where we can take the best practice and we can say, this makes sense. This really helped to reduce hospitalizations. This really helped to make sure that we didn't have infection control issues and so on. So we're going to continue those practices, but we don't have to continue the ones that we didn't see as helping the residents. And most importantly, our volunteer services were able to be an integral part of our residents' lives. So what changed? Well, oftentimes the residents in our households or our apartments, if they wanted to, they went to the hospital, they had their 3-day stay, and they came back to the organization in order to utilize their Medicare benefits, they had to go to the skilled nursing facility. Under this new system, they're able to go back to their apartment, stay in their apartment, but have home health services come in and help them. We can still, with our home health, provide emergency and ongoing services to our Prairie Point residents. We can serve more people without needing that bricks and mortar. And there's a lot less red tape, greater flexibility. So some of the examples, so say somebody has a hip fracture. So historically, again, you'd need that 3-day hospital stay. You'd receive nursing, pharmacy, and therapy through Attic Angel Health Center. But you'd still be paying for that apartment unit or that household unit or the Prairie Point unit while you were getting services in the health center. And your coverage was dependent on how you were doing in therapy and were you making progress or not. And you really couldn't leave the skilled nursing facility and still have Medicare pay for it. So now, after hospitalization, people can go back to their own apartments, their own units. Home health provides that additional nursing if it's necessary and therapy. They can continue to reside in their home, their apartment, during the rehabilitation. And you have much greater flexibilities where you spend your time. If you want to go to your daughter's house and stay overnight because there's a snowstorm, it's not an issue with your Medicare payments. Just another example as far as if it's a stroke. So you're discharged to the nursing facility, therapy might be prescribed, but at the skilled nursing facility, if you can't take part at therapy, Medicare doesn't pay for that. You have to be making progress and show progress along the way. So anyway, so really no change now because Medicare was never intended to pay for all nursing home care all the time. And that's really one of the things in making this transition that we found was the biggest hurdle is educating people about what Medicare does pay for. It was never intended, it never will, it never did pay long-term nursing care. It just didn't. It would have to be specific periods of time meeting specific criteria. This slide is a busy one, but I think it shows a lot. On the top, there's a lot of the forces, some of the market forces that John mentioned, that are really pushing people towards a continuum from the more independent to the more dependent, all the way to from age-restricted housing to hospital. So you've got the demographics, you've got rising penetration rates, you've got social engagement, people wanting to be more with other people and have the emotional well-being support, and the reality there's fewer family caregivers to help people stay in their independent homes. So all those forces are pushing it towards a higher acuity. But then you've got all these other payment forces that are pushing it towards less acuity, like population health management, the post-acute care collaboration, the fee-for-service, and we talked about that, fee-for-service versus the bundled payments or value-based payments or patient-driven payment models, and basically looking for lower cost structures. So if you think about this, 20 years ago, hospitals wouldn't have discharged a nursing home for rehab. It's like, no, we rehab here. And they realized that, wait a minute, there's a way to save some money at this if the nursing homes could provide some of that therapy. And so they found, as you can see, these costs per day along here, various rates, long-term inpatient. So skilled nursing at $500 a day was like 20 or 25% of the cost of those other alternatives. Hey, this makes a lot of sense. Let's do this. Okay, fast forward. We're now 20 years down the road. And now people are saying, you know what? Let's look at between home health, home with home health care, or assisted living. Look at that is 5 to 10% of the alternatives. So there's a way to, again, provide those services, still have them high quality, still have them meet resident needs, but save the system, the whole system, some funds. This information, of course, is from the National Investment Center for Senior Housing Services. This slide was interesting too. We talk about the difference between fee-for-service, straight Medicare, or managed Medicare Advantage plans. And this was based on some goals that the Health and Human Service Secretary had stated back in 2015, that by 2018 they'd hoped that there was only 50% fee-for-service and 50% alternative payment models. We're not quite there. We didn't make that in 2018. I think Wisconsin's more like 31, 32% of residents are choosing Medicare Advantage. Neighboring states like Minnesota are up to 41%. And this is a slide from Clifton Larson Allen at one of the presentations that they made at Leading Age. So, why do assisted living rehab? There's a lower cost of care. There's the 3-day qualifying stay is usually irrelevant because, again, those Medicare Advantage plans have different models, that they have different rules that they play with. The skill competency is really in the DNA, excuse me, in our DNA as providers. It still can help cater to resident desires to be in a less onerous, more environmentally friendly environment. And it's a nice solution for private pay and commercial payer markets. So some of the other changes that are taking place, the news articles. So analysts are watching this Medicare Advantage rule changes so that reimbursements could be made to assisted living facilities. So you could use your Medicare Advantage benefits in an assisted living facility and do that assisted living rehab stay. Some senior living companies have done this really kind of risky step of launching their own health insurance plans and then cover their own services through their own health insurance plans. And there is a bipartisan budget act that authorizes Medicare Advantage special needs plans, the SNPs, and that covers, again, seniors who live in institutional settings such as assisted living. Some of that is even giving funds to have ramps made and so on in residents' homes and using Medicare funds in those really innovative ways. So what have we seen as far as number of admissions? Quite a few changes. In 2016, we had 136 admissions to our little 44-bed facility. 2017, it was 109. In 2018, it was down to 49, but still high occupancy, still a 90% occupancy. The admissions from the hospitals certainly have decreased from 92% down to 64%. We've had cost reduction in the daily rate, so that some of those savings that we said that were taking place, because we don't have to meet some of those regulations, have some of the MDS, minimum data sets, nurse and so on, complete them. We saw the daily rate drop in our nursing home from $411 a day down to $380 a day. But our staffing hours per patient day, we remain at 5.0 direct care staffing hours per patient day. That's a 5-star benefit. We're one of the few nursing homes that since the 5-star system came into place, we maintained that throughout the number of years, except for one quarter when we dipped down to 4 stars. So we see the advantage of having quality care, excellent services, but giving it in a little bit more independent way, something that's a little bit of a variety for people. Again, we thought we were in a good financial position, so that's a good reason to do it now. Our morale was very high, the turnover was low. We have stable leadership. As mentioned, I've been there 23 years, our COO has been there for 10 years, CAO 10 years, Director of Nursing, high turnover physician, has been there over 20 years. So we have a lot of stability. Also strong census. We're in a position of strength. We have great clinical outcomes with our ratings. So we thought, rather than bleed out and worry about, how are we going to make this? Are we going to be able to survive and kind of limp along? Let's identify, as the angels have done for the 130 years, what's going on in this area? What can we do to make a difference? And how can we help people to serve their needs in a better way? Thank you very much.
Thank you very much, Marianne. It was very informative. And Marianne explained how Attic Angel handled a transfer or closure of the skilled nursing service to the assisted living. Now we have the other portion, which is home health care. And we have a fortunate today, Ms. Kelsey Abel, who is the Recover Health Branch Administrator. Recover Health is a Medicare, Medicaid certified home health agency that provides a full range of in-house services throughout the upper Midwest. Kelsey has a Bachelor of Science degree from UW-La Crosse. She has spent the last 8 years in various home health activities, in a leadership roles committed to making a meaningful difference in the lives of the clients served. Ms. Kelsey will describe how Recover Health Care services are coordinated with Ethic Angel community and how patients in various locations are receiving care and how it is reviewed and evaluated for quality services. Please welcome Kelsey Abel.
Thank you. All right, like mentioned, I will be discussing kind of that transition of care in which we were able to help support Attic Angel in providing additional services after they decertified and we're making that transition to the assisted living. So as mentioned, we are a Medicare and Medicaid certified agency providing home health services. That really consists of a full range of home care services, and we have several branches, over 30 offices in Minnesota, Wisconsin, Iowa, Nebraska, South Dakota, and Colorado. Based on the types of services we provide, we could be providing services up to 24 hours a day, 7 days a week. And our goal in collaboration with providing home care is really to make that everyday living easier. We're helping a lot of clients who might be recovering from hospitalizations, potential surgeries, special medical conditions, behavioral needs, as well as chronic illness, so a lot of long-term care as well. We are regulated by the Centers for Medicare and Medicaid, so federally regulated as well as through the state of Wisconsin to ensure compliance. We have lots of rules and regulations that are changing, a lot that have changed beginning this year in 2019, but all of those things to help ensure compliance. So not only are we providing services in many different settings, but that piece helps to make sure that we're still collaborating care that's necessary and that's still meeting compliance standards since we're not necessarily operating out of a facility. As many people mentioned already today, most people that are here can probably all agree that being in your own home is the best option for receiving care, but also for having the best outcomes. When you're not feeling well, when someone goes to a hospital stay or they're in a skilled nursing facility, many people are looking for that chance to be able to get home, feel that that is where they're most successful. In my past experiences working in the assisted living industry, I got to see that firsthand. Many residents who lived long-term in assisted living wanted to get back at home. They had better outcomes, they knew their caregivers, they knew the people that were closest to them, that knew their routines, and that was a way for them to be able to thrive a lot better. The quote that I have listed here is actually from our CEO that mentions our goal is really to help individuals age successfully in their home. One of the ways that we're able to achieve that goal is by building these unique partnerships with healthcare providers. Helps to create an opportunity for coordination of services, allowing all to give greater care for our clients. And that really speaks to our collaboration with other agencies, assisted livings, to be able to provide the best care to clients in their home. So who receives home care? I spoke a little bit about this, but it could be people that are disabled or chronically sick adults and children, people needing assistance while recuperating from illness, injury, or hospital stay, and those needing physical occupational therapy and have a difficult time leaving their home. So again, oftentimes as people age in place, it might be very difficult for them to get out to an outpatient clinic to receive some types of services that are needed. And again, wanting to continue to thrive and meet those goals, best being able to do that in the comfort of their own home. So who's on our home care team to provide healthcare services? We have skilled nurses, so registered nurses as well as LPNs that would provide any of the skilled nursing needs. A physical, occupational, and speech therapist. We have home health aides that come in and provide a lot of the activities of daily living to help support some of those other services. And then we also have a Recover Health pharmacist on staff that provides that additional support and oversight with medication review. Covered skilled services. We speak a lot about skilled services in home care, meaning what can be provided that's considered skilled. So again, we have our physical, occupational, and speech therapy. For skilled nursing services, we might be in doing wound care treatment. We do a lot of teaching and reinforcement with that. A lot of times people are trying to eventually do these cares for themselves, so they don't need home care in there indefinitely. So we might be teaching a caregiver or a family member or the client themselves to learn about their disease process and be able to manage it more independently. We might be supporting monthly injections. We do IV infusions and care related to that. Again, reinforcement and education. We're oftentimes helping support some clients that have monthly catheters. In some of these assisted living settings, they might require additional oversight of a nurse to help manage those types of things based on the staff, the non-skilled staff that they have, who's helping care for those residents. So we can be in there from an oversight standpoint to help support some of those needs. And then observation of medication side effects and changes. So through all these different types of services, it's not always providing a direct patient skill. A lot of times it is going in and observing to making sure that if we're noticing signs and symptoms of someone getting worse or potential for rehospitalization, we're the eyes and ears in there to help prevent that and maybe make a change before they potentially have to be rehospitalized. So we talked a little bit about payer services and how that is changing. Recover Health does accept many different funding sources, Medicare Part A being a huge part of that. And the really great thing about home care, especially with that benefit, is home care is covered at 100%. So that's no cost to the client receiving those services under that benefit, which can definitely be a huge added piece if they are paying for assisted living services or other types of services in their home instead of having to fork out more money for additional care needed under the Medicare Part A benefit that's covered. We also work with Medicaid, private pay, many different third-party insurances, as well as long-term care insurance. We talked a little bit earlier, and you've heard where home care can be provided. Anywhere the patient calls home, except the nursing home. So that could be your independent residence. It could be a senior high-rise. It could be an assisted living. So all of those different varying places, you may be alone at home, or you may have 24-hour caregivers around you, but home health can still be coming in and helping provide that additional support. So as you can see, kind of helping to continue people aging in place, and like I already mentioned, because many assisted livings are not Medicare certified, they're not using that Medicare benefit, which means that we can help create a significant cost savings to the resident because they're getting those additional services, potentially at no cost to them. So now a little bit about our collaboration with Attic Angel and how we kind of came to be with that model of care. So our collaboration model really covers a joint and coordinated effort between a home care agency like ourselves, who are certified under Medicare and Medicaid to provide those services. And we also partner with Part B outpatient providers to provide Medicare skilled nursing and therapy services. So what that means, and many of you might be familiar with this setting, but sometimes in the assisted living complexes, they may have a therapy company that's located within those settings that are on site that are there to provide Medicare Part B services as an outpatient service for people that might need therapy. So with that, of course, through Medicare Part B, it's not covered at 100%, but it's another alternative and option to have that care that's needed right there on site. So with our collaboration, we're actually able to work with those therapists and contract with them to provide services under home care with Recover Health. So what that might look like if you have worked with a therapist on site before and now you might need home care, you can still receive home care and have that same therapist who you know and maybe have worked with several times come and see you in the comfort of your own home. And like I mentioned previously, those that we know and are most comfortable with working with already, they know your routine, they know your likes and dislikes. It's a lot easier and it's a lot more conducive to have better outcomes when you are already working with someone that you know from that continuity of care perspective. So again, residents can have access to all this in their own home. There's the cost savings piece with that additional level of care. And a huge part of this that's really the benefit to the resident who it impacts the most is that seamless transition of care for people who already have worked with that therapist before and now they get to continue to have therapy with them. We're also able to provide innovative clinical programs specific to senior living with that emphasis on their overall well-being and prevention. And then there's a large part that is focused on care coordination and care planning. So this means coordinating with residents' physicians, all that are involved in their care, the nursing staff that might be at the facility, and everyone so that people are all informed about that client's well-being and we can work together to make sure we're providing care specific to them, meeting their needs, and then also to help reduce rehospitalizations. This is just kind of a picture that is another take on kind of our patient-centered care philosophy. So our client is always at the center of that by involving all those different aspects of care, having the skilled nursing that we might have oversight on, therapists involved, a home health aide, as well as collaboration from that assisted living and all of their nursing staff. We're able to assess for any risks that might, again, potentially put them or increase their risk for rehospitalization. We also have some use of telemonitoring that we use to check in on our clients to help kind of drive the home and focus for diagnosis-specific calls that would keep them out of the hospital. We provide a lot of patient education, clinical interventions that are specific to their disease process or diagnosis, and a lot of education around self-management of what that looks like for them. And then again, all of those people working together to help kind of act as that stop and watch so that if we see any types of changes in their care, we can help, go out there, make a visit today, see if there's something that can't be done to prevent them from going into the hospital and kind of going through that system again. This has led to and will continue to lead to improved clinical outcomes, and like many people discussed already, down the road, home care as well is going to be reimbursed for paid for performance, and it's all based on our clinical outcomes. So how well we're able to improve people's conditions from when they start care to when they leave services with us. So there is a lot of regulation already, but even in the payment structure to be focused on the client and making sure that their outcomes are being improved along the way. And of course, all of those things also lead to improved resident engagement and satisfaction in their overall care that they're receiving. Mine was a little fast, I think I went through, but that really speaks to, again, that collaborative effort of care. And us as a home care organization, we are located in many different cities in Wisconsin, as well as all the other places that I mentioned. But being a home care agency that is really focused on being that resource for the community has allowed us to create unique partnerships that, again, are focused on the changes of healthcare and how we can be a part of that to help people age in place for as long as they can and, again, prevent rehospitalizations and overall the best care for the clients that we serve. So thank you.
Thank you, Kelsey. Let's take 10 minutes. It's about 3-4 minutes after 11, and we'll see you back in 10 minutes. Thank you. I want to take this opportunity to thank Oakwood for hosting us here in this nice facility. We appreciate the services they offer us. And please, I want to remind you, if you take a moment to complete the evaluation sheet, we appreciate it very much. It is with great pleasure that I introduce Mr. Tim Conroy, Executive Director of Capital Lakes. He has a Bachelor of Science degree from Syracuse University and a master's degree, MBA, from Southern, third page. Oregon University. He's a licensed nursing home administrator in Wisconsin and Oregon. Tim is a member of the Rotary Club of Madison. He volunteers as a young sport coach and junior achievement. He serves on a number of nonprofit boards, including Leading Age Wisconsin and New Bridge in Wisconsin. He lives with his wife and 4 kids in Madison. And we saw the picture of the kids. They are lovely. They're really lovely, yeah. And they go all in school. Tim will detail how skilled nursing services are covered at Capital Lakes and how they are meeting the challenges that have been articulated and delineated earlier with the previous speakers. Please welcome Tim Conroy.
Thank you. Thank you, everyone. Good morning. Yeah, this has not been the most productive winter with all these snow days and 4 kids, so it's nice that they're in school, and I hope they're in school tomorrow as well with more snow coming. We will see. So talk a little bit about Capital Lakes. We are a continuing care retirement community, or a life plan community, which is another kind of a newer name for that. We offer independent living, assisted living, and skilled nursing. And I will get into what we do with skilled nursing and how we're kind of attacking that. Looking at the future for Capital Lakes, we will add apartments to our independent living and larger apartments. We're finding people want larger living spaces. So the days of a 500 square foot apartment, the need is still there, but more people come in looking for a 2,000, 3,000 square foot apartment, which is a lot. So, but people want them. Assisted living as well, we want more apartments and larger apartments. Our current assisted living are about 400 square foot studios, and right now that's too small. We've been combining some units and making 1-bedroom apartments. And to build, if you look at the new assisted livings going up all around the country, and especially here in Madison, they're larger. They are like 1-bedroom apartments. So there's a living area and a sleeping area. So that's the future of assisted living. And then skilled nursing, keep skilled nursing, but have fewer beds. The need for all the beds, as John has mentioned and as Mary Ann has evidenced, is going down. And how do we go after that? Because skilled nursing costs a lot of money to operate, and if you're not doing it right, you're losing a lot of money. So looking at the different challenges that we face, and I'm going to focus now on skilled nursing. Medicare needs to save money. There are, as John showed in his slides, way more people who are on Medicare now and far fewer people working to fund Medicare. And we've all heard with the Medicare Trust that not that it's going to run out of money, but there may not be as much coming in and going out. So you need to save money. One way to do that is get people out of the hospital. More outpatient surgeries. That some people have a knee or a hip done and they go home that day, before you're in the hospital for a few days, and then going to the skilled nursing. So outpatient surgeries save money, fewer admissions to hospitals save money, and fewer admissions to hospitals means there are fewer admissions to nursing homes, which we've all talked about. This is some numbers from 2013 to 2015 for Medicare admissions to a nursing home in Wisconsin, and you can see what the trend is. It's going down. And it continues to go down. It was almost 1.2 million Medicare covered days in Wisconsin in 2013, and down to about 1 million in 2015. That is a lot of money. One Medicare admission at Capital Lakes, if you just average it out for a year, is $500,000 in revenue. That's a lot of money. And that's all across the country. The different RUG rates, which is how we're paid, are different depending where you are. But some places are $900 a day. Madison's closer to $600 a day for a person who needs a lot of care in the nursing home. So what have we decided to do? Capitol Lakes is going full bore into skilled nursing. We're making a smaller nursing home as time goes on because we have fewer people, but we're also making sure that we're a major player in Medicare because people do need Medicare from a nursing home. You have comorbidities, which is one or more illnesses or things that you're hit with at the time. You can't go home and get that care. You need to be in a skilled nursing setting with 24-hour nursing care. So we're there for that, to make sure that we are better at caring for people who are far more complex. John showed that picture of the 1960s in a nursing home that would be independent living. 10 years ago, the nursing home is our assisted living today. And our independent living, a lot of people could probably be in assisted living. And that goes for a lot of places everywhere. It's people staying home longer and then transitioning. Independent living means you don't need any services. And that's great. And you may have some home health services. You may have some home care, which is just unlicensed. Someone comes in and helps you with your laundry or helps you with your, make sure you're taking your medications, that sort of thing. We've trained our staff in far more training areas to increase complex medical patients. Those are the people, as I mentioned, that come to skilled nursing now. So our staff need to be trained on how to care for them and care for them well. Mary Ann mentioned all of the regulations. There are so many regulations that we deal with, and we need to be ahead of that all the time and make sure our staff understand that. So it's working with the hospital, working with physicians to make sure our staff can handle that. Accountable care organizations are something that have been set up, and Capitol Lakes is a member of the UW Health Unity Point Meritor Accountable Care Organization, which means that we work very closely with those two hospitals and share data to prevent residents that come to Capitol Lakes for rehab from being readmitted to the hospital, because that costs more money. And we want to make sure we do a good job of that. It also means that the 3-day hospital stay, so you could get your Medicare benefit, can be waived because we're part of this ACO, and you could come directly to Capitol Lakes from the emergency room, or you could come from the hospital and you're there for one night. It's different things like that. And then it's our therapy department, which we use an outsourced therapy company called Consanus, who are excellent. They continue their training. They depend on us for their revenue to pay their employees, and they continue their training to make sure that they're staying ahead of all the Medicare regulations and changes. And there are more changes coming down the pike now to make sure that they're providing the services that we need. Therapy is going to be, the emphasis on it will be lessened as more nursing stuff comes into play in the very near future. So it's how do we work with therapy and how do we work with skilled nursing to make sure that our residents are getting what they need in our nursing home. So Capitol Lakes is currently the leading referral source for UW Hospital for skilled nursing. So the majority of people discharged to a skilled nursing facility from UW come to Capitol Lakes. We have over 500 admissions a year for people on Medicare and an insurance product. And nowadays, they're here between 10 and 14 days. That's it. It's a short stay. Some people are there for 2 days, 3 days. 10 years ago, we wanted to average a 40-day Medicare stay. 10 years ago, that's what we wanted. Now it's 10 to 14 days, and we work with the hospitals to make sure that these people want to go home, and they go home safely, and they go home as quickly as possible. So it's how do you work on that and make sure that we're doing the right thing? It's communication back and forth with the hospital, with our team at Capitol Lakes, with doctors, with patients. Doctors are at the nursing home more often now, rounding, seeing their patients. They use nurse practitioners as well to help do that. And it's to make sure that all the care is coordinated properly. That's really the key. and then offering therapy wherever a resident is. So if you are discharged from Capitol Lake Skilled Nursing and you go home, you'll most likely have therapy. If it's in your home, it's through a home health agency like Recover or all the different home health agencies in town. It could be outpatient therapy where you come back to Capitol Lakes and have therapy, or you go to a court's office and have therapy, or UW or St. Mary's, wherever. Or if you're in assisted living, the therapy can come to you, which it's pretty simple. So looking at our role in this whole thing, we're looking at medical home. So you have a medical home in sense if you are go to UW Hospital or Meriter at this point. That's part of your medical home. Your physicians are there. When you need the hospital, you're there. Your labs are done there. Your rehab's done there. Capitol Lakes wants to be part of that medical home. So if you need something, you think of Capitol Lakes for your rehab. And we want to make sure that all that communication is constantly there. We're able to now pull out our phone and see our medical history, which is pretty amazing. And we want to continue that so everyone knows what's going on with themselves, knows what's happening, and your physicians and all the different care providers help. Because we want to rehab people quickly and get them back home. That's the best setting for anyone, is home. And at some point in life, home may be an assisted living or a retirement community, but it's still home, and that's where people are comfortable. And we want to make sure that we do that. So therapists go to your home to make sure that, to see what you're dealing with there, to make sure you work on, I have 5 stairs I need to go up every day. It's these extra visits and that sort of thing. And we want to keep you independent. And the highest level of independence possible is our goal, because we want people to be happy and healthy. So that's kind of how Capitol Lakes views it. It's a different take than other places, but we know that there's going to be a need for skilled nursing, a smaller need, but we are doing our part to make sure that we are the player in that and continue to do a good job. Thank you.
Thank you, Tim. I want to share an observation with you. This year in January, I was in Toronto, Canada, and it was on the news, on television, where a patient came to the hospital for a hip replacement, 10 o'clock in the morning, and was discharged by 3 p.m. Her husband showed that driving up to the outpatient clinic, and she was walking to the car and going home. Obviously, she would need some home health services once she get there. But that was big news, a newspaper, and I don't know if this, eventually they may move towards that goal. I thought it was interesting. I wanted to share it with you. We are privileged today to have Zach Crobart. Is a Madison native. He has a Bachelor of Science degree from Eau Claire. He has extensive experience in multiple long-term care providers in Wisconsin and in Illinois, in both for-profit and non-profit environments. In his present role as Oakwood Hebron Oaks Nursing Home Administrator, he observes a team of 140 caregivers and ensures that the regulation is adhered to. Zach will describe the delivery of skilled nursing services at Oakwood and how market and government challenges are managed and its impact on the quality of service. Zach?
Hello, everyone. I know you guys have gotten a lot of information today. I'm hoping to clarify a bit more for everyone. Just to start off, Oakwood has 2 campuses, one on our east side called Prairie Ridge, and then this is our west side, our University Woods campus. And we do have skilled nursing facilities, also known as SNFs, I might reference that during my presentation, assisted livings and independent livings on both campuses. I wanted to start by giving you guys a little background on SNFs. As John had said, they are one of the most regulated industries in America. I believe they've surpassed nuclear power plants with mega rule changes. They are also more regulated than hospitals, and the reason for that is that the residents reside with us for longer periods of time than hospitals, so there's more requirements that we need to meet to make it more of a home environment. SNFs are required to meet certain expectations for staff education, our admission processes, discharging residents, even how many times a resident is seen by their physician once they're in the SNF. Anytime there's an incident involving a resident, we need to investigate and put plans into place to prevent those from happening again. And those can be quite challenging when it's a simple skin tear or a fall or a bruise. Also, anytime there's an allegation of abuse, we're required to report it within 2 hours to the state. That's day or night, 365. We're also surveyed minimally every 9 to 15 months by DHS, which again is the Department of Health and Human Services. Oh, I should probably put my slide up. I haven't moved past this one yet, so don't worry. Haven't missed anything. Along with our annual health surveys, we are judged by our staffing, our quality metrics, and our life safety, which is the building's physical structure and making sure it meets certain requirements. And all of these are scored, which give us a star rating. The star rating can affect things like being a host for students who want to be trained in regards to nursing and CNAs, or partnering with hospitals and being partnered with ACOs, which are accountable care organizations. Overall, it's certainly a challenging environment to work in. And next, I will give you a little background on Oakwood. Oakwood, we've been operating since 1948, so 2019 is our 71st year. Not quite as long as Attic Angel, but we're getting up there. We opened an additional 42-bed skilled nursing facility on our Prairie Ridge campus in 2008. At the same time, Hebron delicensed from 137 to 95 beds. Then in 2017, Hebron delicensed again from 95 to 70 beds, as it made more sense from an operational standpoint and overall less demand. Every month there's a cost associated with the demand of beds in a SNF, and if they're not utilizing it, you're basically just paying for empty rooms. There are some additional services that Oakwood has that a lot of the other SNFs don't. Oakwood is actually pretty lucky to have so many resources on its campus. Every facility has nurses and CNAs, but not every facility has its own therapy on site, or its own dietitian in-house, or pharmacy. The pharmacy is huge and saves us a lot of issues with getting medications on time, and this allows a better continuity of care for all levels, whether it's in our SNF, assisted living, or independent living. And this allows us to provide better service than contracting with another company and following these processes, versus following their processes. It's a lot easier to manage our processes when we're doing it all in-house. Having these additional services also allow us to have better control of some of our costs. Some of the key trends, including reimbursement issues, national staffing shortages, new technologies, and overall model of SNFs nowadays. The importance of having these additional services I mentioned are huge in regards to controlling expenses. Every facility has to control their budget nowadays, that's a given. Even more so as the federal reimbursement is changing and getting tighter and tighter. Medicare reimbursement is based on the amount of skilled therapy the resident receives. So if the resident is high functioning and they don't need as much, they don't need as many minutes, and therefore it's less reimbursement for the facilities. They're likely going to go home sooner. And on the other side, if they're pretty acute, they may not be able to participate in the therapy as much as we require. There are also nursing levels of which a resident can be skilled under, but either way, a resident is only eligible for 100 days of skilled care in a benefit period, if needed. I know that confuses a lot of people. If you're eligible for Medicare, you typically need to spend 3 midnights in a hospital before you're able to be admitted to a SNF. The first 20 days under Medicare are covered 100%. Days 21 to 100 is covered at an 80%. Again, that is if there is a need. What I mean by a need is if they are progressing in therapy and working towards a goal. If it's a nursing level, maybe it's an IV, for example, They would be covered as long as they're receiving that IV. Medicaid, on the other hand, is the lowest reimbursement method. Typically, and it varies between state to state and different facilities, but between $160 and $180 a day versus the $500 to $600 for Medicare. Medicaid is a long-term payment method for our residents, and to be eligible, you typically need less than $2,000 in assets for a specific individual. Wages are also going up every year, and usually at a higher rate than the reimbursement, which you can see might be difficult to handle as salaries are one of the largest costs for healthcare facilities, as well as overtime. And you have to pay overtime when you have staffing shortages and need your staff to work extra hours. A lot of facilities might try to keep lower wages as a way to control costs, but then it's even more challenging to recruit and maintain adequate staffing, of which there are national shortages and numerous programs being put into place to recruit and maintain staffing levels in long-term care environments. Wisconsin has a recruiting and retaining program where bonuses are offered if staff are working at a facility for 6 months. A lot of facilities are offering bonuses to attract new employees, some I've seen as high as $12,000 for a single person. A lot of facilities are having to turn using agency companies as well that provide additional staff, which is about triple the cost of having your own employee. Fortunately, Hebron has not had to use agency employees for just over a year now, but typically spending an additional $20,000 a month just to have those people in-house caring for our residents. As technology advances, so does the demand for facilities to use these technologies. With this can be quite challenging from a cost standpoint as well as implementation. It's not as easy to integrate new technologies, especially with older facilities. New or changing regulations also make a big impact on the ability to be used for care for the residents. As you can imagine, it's not easy just to build a new building or change a current building structure to meet the new standards. Some of the new standards is an EMR system, which is an electronic medical record. And as has what's been brought up, it's giving you that information electronically from anywhere on a smartphone, on your computer. Every nurse can access it, every person sitting in their office can access it, your doctor can do it from their office. But things that are associated with that are just having computers for all the staff to use, needing Wi-Fi. And in a lot of times older buildings, the Wi-Fi is poor and it's costly to implement new systems. Plus you need to teach the older generations how to use this technology. We're all in a time where facilities are trying to be more hospitality focused than the older industrial model that has the long traditional hallways with shared rooms. And I know that doesn't appease anyone. Personally, I wouldn't want to be in a shared room either. Continue with trends and cost drivers. SNFs are getting more pressure from CMS, which is again the Centers for Medicare and Medicaid Services, hospital systems, and insurance companies. Hospital requirements and reimbursements are changing as well, which then trickle down to us and we're forced to comply. If we want to continue partnering, we're expected to shorten the stay of our rehab residents. And that's not always easy based on the diagnosis. We're also seeing an increase in resident acuity, therefore needing more care and more time from our aides and nurses to treat those individuals. And we already know staffing can be a challenge. Another true challenge that I want to point out is finding truly compassionate and dedicated employees who provide excellent care. I mean, everyone wants that. Nurses and aides have an extremely demanding job, from the mental toughness it takes as well as how physical it can be. So finding the right person is crucial. We're also seeing fewer residents wanting to come to a SNF because a lot more people are able to get the care they need at home, as well as going to an assisted living setting, which again is significantly cheaper. There's also less reimbursement for long-term care residents, as well as more regulations in a SNF setting. And to stay on top of surveys, there's a lot of time preparing, educating, implementing processes so your staff can meet the requirements. And again, this can all be quite costly. If you have a citation that meets a certain level of severity, it can cost you $2,500 a day until it's fixed. And again, if that goes on for a month, that's a huge financial impact on your budget. To discuss ACOs briefly, and if you're a part of one, you would check your eligibility with your provider, but this would allow you to pass the standard Medicare guidelines for hospital discharges to a SNF. Traditionally, you would need to spend 3 midnights in a hospital bed before being able to be admitted to a SNF. What it means for Oakwood is you would be able to come directly from the hospital, the clinic, or an ER, and that's a big impact, being able to come directly to us versus staying those 3 nights in a hospital. The overall goal of ACO is to save the system money because we all know, again, Medicare dollars won't be around forever. As it's already been talked about, Medicare is probably the most preferred payer source for residents in the skilled nursing facility because it's determined based on progress and goals versus the insurance companies dictating the time they are able to spend. I've worked with insurance companies, again, where they would authorize 14 days of care no matter what has happened, whether it's a stroke or an amputation. And it's hard to get people back to their baseline in that amount of time sometimes. Medicare reimbursement is changing. It's a model in which something new for everyone, and we'll need to learn the new process. With having more acute residents but expecting to discharge sooner puts more pressure on everyone, from our therapy staff, nursing staff, and the residents and their families. Because if you've ever had to find a place for your mom or dad, and you only have a few days to do it, it can be quite challenging, especially if they can't go back home to care for themselves like they used to do. The insurance companies, which are growing in popularity because they're offering deals to get members signed up, make admissions for a facility very challenging by having a lot of requirements that need to be met before they'll allow a resident to be admitted to the SNF. They like to take the time to authorize the resident before they can be admitted. And then once a resident is admitted, it's at the mercy of the insurance company of how much time they want to authorize. And that seems to be less and less as we know the length of stay is getting shorter. Why is rehab so important? The reason quality rehab is so important, not only in Madison, but for everywhere, is that there's a certain level of care in SNFs that just can't be met in the assisted living environment. For one, a common difference between the SNF and AL is that there's 24/7 RN coverage. This allows for dealing with higher acuity nursing needs. There's a lot more regulations and requirements that are needed to be met, such as certain levels of staffing, both from a nursing and CNA standpoint, from a social service standpoint, nurse practitioners, physicians, and etc. As well as it's a lot cheaper to be in a SNF than the hospital, has been pointed out already. SNFs are that next step after a hospital stay to continue recovery, and assisted livings seem to be the new SNF. Additionally, home settings may not allow for rehab at home for various reasons. Intensity and frequency of rehab greatly improves your chance for successful recovery and shortens recovery time. There are also transportation issues if people can't get to and from appointments easily, and there is a certain equipment that is utilized in therapy gyms that again just can't be duplicated in someone's home. In short, we want to continue providing skilled rehab services and believe it's a great service to our continuum residents as well as those individuals from the community. We want our focus to be in short-term rehab while providing long-term care needs in an advanced assisted living setting that will be more beneficial to the individuals.